A warm welcome to you, Martin. Over to you. Thank you.
Kia ora katoa, ko mātātua te waka, ko putuaki te maunga, ko whakatani te awa, ko Ngāti Awa te whana apanui te iwi, ko Martin Chadwick toku ingoa. So kia ora everyone, as Gillian mentioned, my name is Martin Chadwick. I'm the Chief Allied Health Professions Officer at the Ministry of Health, and I'm going to try to talk to you today around clinical leadership and the role that it has to play with regards to improving clinical care. So just going to share my screen here. And so what I want to do to begin with is to try to put this into a little bit of a context. And if I'm looking to what is my left, it's because I'm looking at my second screen, but bear with me. So what I want to do is to think a little bit about the context of we're all relatively familiar with the concept of evidence-based practice, and evidence-based practice being that intersection of the person, their preferences, what they're looking for, their clinician and the experience and the best available evidence. Now I want to try to take that a bit further and start to put that within the context of the environment, the organizational context and the person's environment. And within that, to start to think about evidence-based practice really being about the decision-making that occurs in the intersection of all of those points of the broader context, the person, the clinician, and the best available evidence. And so that's probably context number one. The second is with regards to a nomenclature around how we talk about team working. And the first is around intradisciplinary team working, which is about working within a discipline. So my background and my remit is with regards to allied health. So unashamedly, I'm going to talk in allied health terms. So when I talk about intradisciplinary practice, it's about a physio working within their sphere. It's about a speech language therapist working just within their sphere, so on and so forth. As opposed to interdisciplinary practice, which is when you have work which is occurring or care which is occurring between professions. So for example, you may have a general practitioner who then makes a referral to a physiotherapist or makes a referral to a speech language therapist. And so the two professions are working with a very formal interaction between. The third one is multidisciplinary practice, when we start to talk about working with each other. And in the New Zealand context, I think that's very clearly, you look at a rehab type environment where you may have a ward environment, but you have the medical practitioner who may be working with the nurse practitioner that is then working with the allied health team. And so each has got their very distinctive roles, but they then come together to work together. And the last component is transdisciplinary practice, which is when we start to work across. And that's a talk for another day, but it's that sense of how we can work with the sense of there are things that can be shared. There are skills and tasks that don't necessarily sit with one profession. They may sit across many professions, but it doesn't take away from that which is a special and unique contribution of one profession versus another profession. And so it's that hierarchy of team working between inter, multi, and transdisciplinary. But specifically today, I'm looking at improving clinical care and clinical leadership. And I want to take a very, very simplistic approach, but this will hopefully all make some kind of sense. That I look at it, that there's this black box of care that occurs, that someone presents in whatever scenario it is, and they present and they receive this black box of care, and at the end of it, they're happy, they're better. And there's that sense of what occurs within that black box of care. And that's what I want to look at today and try to lift the lid on of what occurs when you have that black box of care. And unashamedly looking at this from an allied health perspective. And so it's about saying that allied health is many professions. And so when we start to lift the lid on that black box of care, is what you may have is that you may have the component which is occupational therapy, and the component which is physiotherapy, and the component which is speech language therapy and social work, and it could be podiatry, and it could be anesthetic technicians, you know, the list goes on and on. The point being that there is a multiplicity of professional groups that may be involved, rounded into that black box of care. And so the issue that I think we need to explore is what happens when we begin to open each individual box of care. Because when we open each individual box of care, that each of these professions have got a history of their own right. They're very proud, and they should be, of what they have done, what they have achieved, and how they have built a body of knowledge over time. And so there is a sense, if you're an occupational therapist, what does it to be an occupational therapist? And what is the history of occupational therapy? And what have been the key contributors to occupational therapy as a profession? And as you start to open each individual box, that what you start to find is that there is a multiplicity of approaches, and there are various gurus that sit within these various approaches that start to look at that it's this approach or it's another approach. And quite often they don't agree necessarily as to what the right approach would be. And so it's a matter of that. What I see as the issue here is that when you then in turn go and start to open up each individual box in turn, that you can run the risk of it becomes turtles all the way down. You know, how far down do you go to try to get an understanding of actually who's right within all of this? Because that's part of the richness of history, of shared learning, that whole gathering of evidence over time. And so it becomes problematic. Who's right within all of this? And so when we look at improving clinical care, it's one of those that what do we choose to do? Do we choose to really go down into the micro, or is it one that we choose to rather come up and start to look more at the macro? And I think it's that latter approach that I just want to spend a little bit of time exploring today and say, well, tangibly, what can that start to look like? And very, very simply, going too far. It's that how do we enact clinical leadership when it comes to improving clinical care? And it's beginning to ask some of the hard questions, because again, there is a history that sits behind all of us and what we do in providing care day to day. But there is that sense, if you think about the environment in which you sit, is to ask the first hard question, which is, what does good look like? So if you're working in a rehabilitation environment, and in my past history, this was a process that we went through at Bay of Plenty. You know, what does good look like when we looked at rehabilitation? Can we adequately define what good is? And then the next question is actually, are we doing it? And so in this particular instance within the Bay of Plenty is working with a very skilled, very talented team there providing rehabilitation. There was that sense of, okay, so you have each individual profession, each providing, you know, very, very good care, but actually, can you define what good is? In this particular instance, where we came to was that sense of saying, okay, so in a rehab environment, if someone comes into our facilities, status post CVA, that there is a sense of that we know that good looks like having an evaluation within the first 24 to 48 hours. Now, the evidence says that that's when you're going to have the most view as to what the potential neuroplasticity is, and you get a sense of actually what is the rehabilitation potential of the individual. And then that lays the groundwork as to what the model of care needs to look like, what the plan of care needs to look like, what you need to be aiming towards for the individual. So there was an ability to take a snippet and start to say that this is what good looks like. But then the next component of that is the really simple question of saying, well, are we doing it? So if you can define good, then the next question is, are you actually doing it? And in this particular instance, what came back was the answer was actually no, that we weren't doing it to the level that we wanted to. That there was the ability to find that good look like that evaluation occurring within the first 24 to 48 hours. But when we actually looked at it and measured it, to begin with, it was only occurring about 20 to 30% of the time. Now, understand very consciously is I'm not trying to say that it needs to be approach A, B, C, or D, or following whichever is the guru that sits within the various professional groups, but rather taking much more of a macro view to say that, okay, so what are the key components that you can hand on heart say that this is what good looks like, and actually start to measure that actually, are you doing good? And I come back to the example that the answer was not as frequently as we desire to. So therefore, we're not providing the care that we desire to provide for the people that are relying on us. So that led to some changes It led to a look at the systems and the processes that we use, and it led to changes. And so those changes could be measured, and in turn, we're able to see an increase that what was 20 to 30% became 50, 60%, and hopefully continue to improve. But it was about asking that very tangible question of what do we need to do differently? And within that, it's about how we start to think much more at a systems level. Because when I think about my role within the ministry, within Allied Health, it is to have that remit to work with the really broad grouping, which is Allied Health. And it's not for me to say what is right or wrong with regards to various clinical approaches, but it is to be able to ask those questions of actually, can you define what good looks like for you within your clinical setting? And are you doing that? And then to even ask bigger questions again and saying that if you make changes, that are we able to understand what difference that has made, but very much at a systems level. So if you think about provision of health systems or health services, that can we actually capture that in saying that because we made these changes, what does that mean for length of stay? Have we seen a change within the length of stay? What does that mean for readmit rates? Have we seen an improvement, hopefully, of your 7-day or your 28-day readmit rates? What are some of those higher system levels measures that we can begin to look at? Because you cannot necessarily say that there's going to be causality, but you can say that there is going to be a correlation. That if you've started to do good that you can define and measure, that hopefully what you start to see is an improvement in some of those system level outcomes. Again, you can't hand on heart say it's because of what you've changed, but you can say that there's a correlation to the changes that you've made and the outcomes that are starting to come about. And so within that, the vision, I guess, of saying, so what does leadership enacted look like? And it's understanding that people present to our facilities for a whole raft of reasons. And leadership looks like that understanding that it's not cookie cutter, that it's not a sense of we need to do the same every single time. And to think about it in a transdisciplinary way, that it's not a matter of saying that we need to ensure that every single profession is represented all of the time. But actually there's the ability to say that for certain presentations that actually social work is going to be the most important group that is going to have to interact with the individual within their context, within their circumstance. It may be that physiotherapy is going to have very little to do with that presentation. But then you may have a different type of presentation, and actually it is physiotherapy which is going to be the lead in that one. They're going to need to work with their occupational therapy colleagues and with their social work colleagues, but they may be the profession that takes the lead within that. And it's being comfortable that it is the ability to work with your colleagues and the desire to see that you're going to deliver the best outcome because you've gone through that process and actually what does good look like within this context? Have you measured what is good? Are you doing it or not in the first instance? If you are, tickety-boo, awesome. If not, what do you need to change? What is the leadership that you need to provide in this type of a scenario to say that actually we are not providing good care to the people who are coming to see us in the first instance? Therefore, if we want to provide good care, we need to change something. We need to change something, but we need to keep on measuring to ensure that any change that we've done has actually led to a difference, that we are now enacting better care as to how we've defined it because of the changes that we've made. And so I end with this one quote, which I have kept for years because I think it just really, for me, personifies the tension that we have to deal with. And it reads that professional expertise and values are powerful inhibitors of innovation because of the vested mindset they create in the status quo. However, expertise is essential to improvisation. And so therein kind of lies the rub, the paradox, if you will. It's about acknowledging that we each bring a very defined expertise and a history and the desire to do the very best. But it's about bringing that to the table, if you will, but not holding on to it too tightly, because you don't want to then try to protect that at the expense of saying, actually, how do we need to innovate? How do we need to change? How do we challenge what we currently do if we're not doing good by the patient, by the person that we see in the first instance? So how do we use our skill set with that whole sense that if we want to improve, improvement is change. But what are we going to change and how are we going to know if that change has made an improvement? which comes back to that point again of what is good. Can you define good? Can you measure good? And then where are you? And so that's the vision that I want to put out there. I think when we start to think about how can we enact clinical leadership, it's keeping ourselves really grounded at the end of it all, that we're all here for the people that we serve. And to be able to challenge ourselves and to say that actually, can we define with confidence what good is? And can we go ahead and actually start to measure that? And if we're not delivering good, that means we have to change, but change it in a way to ensure that you're actually delivering what you want to deliver in the first place. And so that's me. Leaders think and talk about the solutions, followers and think and talk about the problems. This is about leadership, and it's about trying to think about the solutions. So my contact details are there, my email, my phone, and my Twitter account. So very, very keen to hear your thoughts and or questions after the presentation.